I'm going to talk about carotid Doppler protocol and some tips for performing the exam. What I'm going to start with is the standardized protocol. That's very important that within each lab performing carotid Doppler that you have a protocol that is written down that can be followed by everyone in the laboratory. This will standardize the procedure and is very important for follow-up of patients. Because you want a patient who's coming back to have the exam done in the same way that it was done on the previous study, and that way it really makes sense for comparing from one time to another. So really everyone in the lab should be doing the study in exactly the same way, and the interpreters should also be using the same interpretive criteria when they're interpreting the study. So what should be included in your standardized protocol? Well, we'll start with B-mode imaging, sometimes referred to as 2D imaging or grayscale imaging. All of those terms mean the same thing. I like to start with transverse imaging. I think transverse imaging is very important because when you are in cross-section, you can visualize the whole circumference of the vessel. This gives you a good idea about the plaque burden on the vessel. It's also a good way to look at where the plaque is located on the vessel so that you can plan your sagittal approach. You already have an idea of how much the lumen is compromised. It's also very helpful for differentiating between the internal and the external carotid artery, because in the transverse orientation you can often identify branches arising from the ECA, and that's one of the best ways to differentiate between these two vessels. So we're going to take B-mode images or transverse B-mode images of the common carotid, internal carotid, and external carotid arteries. And I may take more than one image to demonstrate different features of plaque that may be present, or take images from different projections. Once I've done the transverse images, then I'm going to turn the probe into a sagittal plane and take images in a sagittal plane, again, of the common carotid, starting at the very most proximal portion near the origin, and then up to the internal and the external. And again, taking images from different projections. This image on the bottom, the sagittal view of the internal carotid artery, you can see the plaque filling the bulb area, and that it has a heterogeneous nature and a very small residual lumen. On the right-hand side is the same vessel, but just from a different projection, and it just gives you a different look at the plaque. So it's important to look from multiple views. Now, as I mentioned, the transverse views can be used to help plan the sagittal plane. Take a look at this cine clip on the left-hand side. What you may have noticed when I started is that in the transverse orientation here, the vessels were diagonal to each other. And when you see a bifurcation that looks like that and you turn sagittal, you'll see the individual vessels, ECA and ICA, one at a time. What's important here is that you take the most inferior aspect of the probe, which is the most proximal part, the foot of the probe, and try to keep it steady over the distal common carotid artery. Then move the most distal portion of the probe, the top of the probe, that's cephalad, to the lateral for the internal and medial for the external. And it's kind of like a windshield wiper blade toggling back and forth between the internal and the external. This isn't a large motion, it's a very tiny motion because these vessels are actually quite close together, just going back and forth, and then making sure that each one of them ties back to the common carotid artery. Why is this important? Because it ensures that we're looking at two different vessels rather than one vessel from two different views, which is a mistake we might make if we pick up the probe and simply move it between the vessels. It's easy to actually look at the same vessel and actually mislabel it as two different vessels. So this will keep you from making that mistake. Another thing you can do, though, to prove that you have both bifurcation vessels is to line up the bifurcation by rotating the probe on the neck so that the vessels are one on top of each other instead of side by side or diagonal. And watch as I do that on the right. I'm just rotating the probe until the vessels are lined one on top of the other. Now when I turn in a sagittal projection, you can see that I have a nice picture of the bifurcation. And so I'm showing the tuning fork bifurcation where I see both vessels at the same time. Is this necessary? No, obviously not. But it can be very helpful because it does prove that you've seen both vessels. Now, which vessel is on top, which is on bottom, that depends on your plane of approach. If I'm coming from a lateral or posterolateral approach, as in this case, which you can tell by the sternocleidomastoid muscle seen on top of the internal carotid artery, well then the internal carotid artery, which is the lateral or more posteriorly located vessel, will be the one that you see on top, with the external on the bottom. On the other hand, if when I changed my approach to line the vessels up one on top of the other, if I moved medial or more anterior, then I would likely have the external on the top because it is more anterior or medially located. Okay. Now, when we talk further about the standardized protocol, let's go into spectral Doppler. We want to make sure that we sample throughout the length of the vessels with our spectral Doppler. And in the common carotid artery, that means that we're sampling from proximal throughout the length. And we're going to take readings or images of Doppler samplings at proximal, mid, and distal CCA. ICA, again, proximal, mid, and distal. And in our lab, we actually include a further distal reading, just as far distal as we can. This really helps in those patients with fibromuscular dysplasia, which is seen in the mid to distal ICA. The ECA, we just take a single reading at the proximal ECA. Unless there is stenosis, in that case, I take at least 2 readings, one within the area of stenosis, the second further distal, to demonstrate the post-stenotic turbulence. And in the vertebral, the area we're most interested in is the origin, but it's okay to take a mid-vertebral segment and get a nice waveform. And then if we see turbulence, we'll look at the proximal segment where stenosis is most commonly located. And if it is abnormal with the bunny rabbit shaped waveform or reversed, then we also want to document the subclavian artery because that's where the stenosis would be. And the key there is to look at the proximal subclavian artery and not the mid to distal segment, because the part we want to sample is proximal to the takeoff of the vertebral, and that's what would be affecting the vertebral flow and causing it to be reversed. In these images that you see to the right, the one on the top shows the stenosis within the ICA, and the one on a normal ICA actually, and the one on the bottom is actually showing turbulent flow with the stenosis. Now, what happens when we document stenosis? How do we alternate or change our protocol in those cases? Well, whenever I have high velocities, I want to make sure that I have confidence in the velocity value that I'm getting. So I take 2 or 3 samples until I really have confidence that this is a reproducible velocity. At that point, I take a reading there, and then I'm going to move further distal, just a short distance, to document the post-stenotic turbulence. And you can see that in these images right here. The top image shows a nice clean spectral window because I'm within the jet of the stenosis. Below that, I have moved further distal, and now the window has been filled in with echoes, indicating that there is a lot of turbulence. This is in the area of post-stenotic turbulence, demonstrated by spectral broadening of this waveform. And you can even appreciate some reversed flow because of the swirling of the red blood cells beyond the area of the stenosis. So this is a typical waveform profile for post-stenotic turbulence.